Good morning. I have a question for Prof Karmakar. I want your opinion on regarding what's your view on the safety and training aspects versus the efficacy of the various thoracic parasagittal blocks?
Okay, I think that's a very good question. I think if you look at how these blocks are done, technically they are very simple. There's no doubt about that. Now, safety-wise, theoretically, because you are not breaching the thorax or you're not entering the thorax with your needle tip, theoretically it is much safer. But really the bottom line is, what is more efficacious, produces anesthesia and analgesia is where today we are lacking in good quality data, good quality research evidence. But I think it is needless to say that given that the mechanism of how these paraspinal blocks, and there are so many of them, produce anesthesia and analgesia is not known, but certainly it is through spread to the neural targets, that is intercostal, paravertebral, epidural, or even dorsal root ganglia, so on and so forth. So if that is the case, then you would think that a drug that is deposited in the proper location, that means paravertebral, epidural, should produce a more dense anesthesia, which I have no doubt it does, and will produce better efficacy. So I think, without sort of beating around the bush, I think today we don't have much evidence or data, but theoretically these techniques are simple. And this is why there has been an explosion of interest, explosion of literature. But I think as practitioners, the question that you have to ask yourself is, are you doing your patient a favor by choosing a block that is efficacious? I cannot say that the paraspinal blocks are as efficacious as the paravertebrals or epidurals today. So in my heart of heart, I know the answer. It's for you all to make up your mind, because at the end of the day, you are at the other end of the needle. Some say the fool is at the other end of the needle. I'm not saying you are a fool, but if you make a wrong judgment, then that is precisely what you are. So somebody wrote, hang your enthusiasm. Just because it's simple doesn't mean it is equally effective. That is an important take-home message. So whenever we make a choice, whatever block you do, you should always think, would you do this on yourself? Would this do this on your grandma or somebody dear and near to you? That is when you make a right choice. I think gone are the days when we should do blocks when we feel what we want to do. I can just give you an anecdotal incident. I was actually visiting the Prince of Songkhla Hospital in the south of Thailand, very close to the northern border of Perak province in Malaysia. A fellow in that hospital said, would you demonstrate an ESP? I can't say I don't do any ESP. I don't say that I don't know how to do an ESP. I said, yes. So they found a patient which was a radical nephrectomy through a lateral incision. In my practice, I would always do a paravertebral and with multimodal, etc. It produces very good pain relief. So because there was so much interest, I said, okay, we will demonstrate to you, this is how you do it, so on and so forth. But I was shocked when the patient woke up in severe pain. Now, what do I say? In my heart of heart, I was saying, what a horrible decision you made. I can never forgive myself, because that patient, in my own practice, would be totally pain-free. And now you have chosen a technique which may be simpler, technically, whatever, and proponents are saying this is what we should be doing. Certainly that day was the day when I said, no, no more. So you will have to find out in your practice what is good. I'm not saying these techniques are not of any use. You have a simple fracture of the rib, and you may find that some of these techniques are very effective. As you see, There is a mechanism by which these drugs spread to the lateral part of the chest wall to affect the lateral branches of the intercostal nerve. It affects the posterior ramus. So if you have posterior ribs, yes, you will have efficacy. So it does not mean that these are not effective at all. But I think we have to be more prudent in our choice of these techniques. Now, there has become difficult for people to understand, what should I do? What is best practice? We don't have the answer. But some of these techniques are definitely technically simpler. Whether they are safer, we don't know. Because you need large volumes of local anesthetics. Whereas paravertebrals, epidurals, you can do with very small blocks, doses of anesthetic. Now, on the flip side, people say paravertebrals are dangerous. I think that's a wrong question. If it was dangerous, I would not be in my job today. People say epidurals are dangerous. Many yesteryears, I'm part of the yesteryear, but even before me, 100 years of anesthesiology gone by, you know. How many neuraxial complications have you recognized in your own clinical practice or in your hospital? I think the incidence is very, very low. What is the important thing is training is important. I'm afraid if we start doing these so-called paraspinal blocks to supplant the traditional blocks, it will influence training and learning of residents, learning of fellows, and so on and so forth. We haven't identified best practices as yet, so I think we have to hang our enthusiasm till we find the answer. So this was a very long-winded answer, but I hope it gives you a whole picture of where we are today and where we should be going in the future. Thank you.
Morning, Prof. This question also addressed to you. Thank you for the excellent lecture. I'm truly intrigued by the newly described retro STCL area target as a new target point. It really seems to be safer. And you also mentioned that you also perform this block of mastectomy patient as a surgical anesthesia with sedation. I'm really, how's the block onset compared to the conventional where we pierce the SCTL for the usual paravertebral? And also, is it for surgical anesthesia you are doing multiple injection or single injection?
Actually, that's a discussion for an entire session. How do I begin? Okay, I try to summarize this all. The innovation of the breast is very complex. Even a paravertebral block from T1 to T6 will not give you complete anesthesia because it has innervations from the cervical nerves, it has innervation from the sympathetic nerves, and more importantly, the somatic nerves that innervate the pectoral muscles, the lateral and medial pectoral nerves are involved. So even with the most efficient epidurals, your patient will still complain of pain. Especially the technique of mastectomy, modified radical mastectomy that they do today for primary breast cancer is they remove the base of the breast from the pectoral major muscle with the fascia. And when they use the diathermy, monopolar, dipolar, whatever they use, and the muscle symmetrically contracts, the patient will synchronously report pain. It's a dull, aching pain. So in my journey of my paravertebral experience is that in the beginning I used to say, I can't reproduce the results of the Mayo Clinic. Because in the early days, in the 90s, Professor Roy Greengrass described paravertebral blocks for surgical anesthesia with sedation. I always found patients complain of pain, not during the beginning of surgery, but during the middle of surgery. Those days I did not understand because the innovation was not so well understood. Secondly, people have also reviewed some of the work by previous investigators. When you give sedation, they have used sedation which today would be general anesthesia. So, of course, you can do a block. When the patient complains of pain, if you preempt it with deeper sedation in ketamine, midazolam, whatever, the patient will not report pain. You understand what I'm saying? So it is possible to do multi-level paravertebral, and then give sedation, and just before they start doing this intervention, give repeat doses of small 10 milligrams of ketamine till they remove the breast base, and then the patient is comfortable. So today our practice is to do 3 levels: T2, T4, T6. This is based on evidence. In a sense, the breast is described to be, or paravertebral blocks would describe T1 to T6. I don't know why they do T1. I used to do a lot of T1 injections too. The breast has no innervation from T1. Neither the muscles nor the parenchyma of the breast or the areola anywhere. No. So T1 is the most difficult paravertebral injection. It's deeper. The pleura is more difficult to identify. So don't even think about going to the T1. So T1 is out. So T2, T4, T6, because they spread from one level to another, and then you can do 3 multiple injections combined with a pectoral plexus block. Now, what is a pectoral plexus is another aspect. Now, the pectoral nerves are described as 2 nerves. It's a very simple way of describing PEX 1, PEX 2. Rafa Blanco is a good friend of mine. But we have these discussions in our own privacy. And we say that actually the pectoral nerves are not 2 nerves. They are 3 nerves, major nerves, and they are intertwined to form a plexus of nerves deep to and between the 2 muscles, pec major and minor. So if you think you can block the pectoral nerves by making a simple PEX 1 injection between the 2 muscles, you must be naive. Now, you need to do 2 injections minimum, 1 below and 1 between. Or you deposit a lot of local anesthetic deep to the muscle, pec minor muscle, where the plexus of nerves are formed. This plexus is not created by me. If you review the literature long enough, the pectoral plexus has been described by an anatomist, Professor Lee from Korea again. And they have described 3 nerves, superior, middle, inferior. They could be the lateral and medial and the ansa pectoralis. It's a different terminology, but they are all. So I think there is a lot of controversy about the breast, but to answer your question, single paravertebral injection or multiple paravertebral injection will not produce surgical anesthesia. You have to combine it with pectoral plexus or pectoral nerve block, and then with sedation. Today, our regime for sedation is to use dexmedetomidine so that patients are lightly sedated. Dexmedetomidine has analgesic properties, so it rescues some of these analgesic requirements. And then we substitute it with ketamine. Despite our best efforts, we still have to give ketamine. Now, 10, 20, 30 milligrams of ketamine is no big deal. So this is sometimes beneficial, maybe for the patient, even for other aspects of perioperative afferent nociception. So hopefully that answers your question. Now, the ESP has also been described for surgical anesthesia. I don't want to laugh it out, but over a cup of tea, you think about it.